Good morning. Welcome to all the new interns. I'm Sage Wiener. I'm one of the faculty members here, and I'm a toxicologist in addition to being an ER doc. And I'm going to talk today about over-the-counter analgesics, and specifically, I'm going to talk about salicylate poisoning and acetaminophen poisoning. And we'll start with salicylates. I'm going to start with a patient that I saw, I think, my first week of fellowship when I was a tox fellow at New York City Poison Control. This is a 44-year-old woman who complained of nausea and vomiting since 2 a.m. Her vital signs were reported as normal. It was the call I got. She had some underlying psych history. She seemed a little strange. And the doc had originally sent some labs on her, but she eloped before she was really fully evaluated. Came back that night with continued similar symptoms. At that point, she was tachycardic. Again, respiratory rate was reported as normal. Rest of her exam was normal, and they said, "Oh wow, she was here earlier. She had some labs. Let's take a look at them." And this is her chemistry and her blood gas 75125, so a respiratory alkalosis. She had a negative acetaminophen level, a negative ethanol level, and a salicylate concentration of 87 mg per deciliter. So she got started on a bicarbonate infusion. Next salicylate concentration was 67. Repeat anion gap was going up a little bit. Potassium was going down. She got some supplemental potassium and continued to improve. And by the next morning, her salicylate concentration was down to a therapeutic concentration, and blood gas was normal. Anion gap was 5, and she was asymptomatic. And if you looked at the initial triage chief complaint, what she had written on the card when she came in is, "I'm nauseous, I vomit, and sweaty. I can't hear well." So this case really, and we're going to come back to it at the end, but it illustrates a lot of really classic features that we see with salicylate poisoning. So there are a lot of forms of salicylate that are available. Aspirin is obviously the one that we're going to see the most, and it's one that we think about the most, and that's acetyl salicylic acid. But there are a lot of other forms of salicylate, both in over-the-counter preparations and prescription medications. Over-the-counter things, we think about things like cold and cough medicines. Most of them these days don't contain salicylates. They're more likely to contain acetaminophen, but there's still a few out there that'll sometimes have aspirin in them. Pepto-Bismol is bismuth subsalicylate, so you can actually get salicylate poisoning if you have enough Pepto-Bismol. In terms of prescription combination medications, if there's two versions of a prescription analgesic and one ends in set and one ends in all or an, the one with set has acetaminophen in it, and the one with all or an has aspirin in it. So Furinol, a migraine medicine, is butalbital, caffeine, and aspirin. Darvon is now off the market, but that was an opioid with aspirin in it. Percodan, it's another one of those pairs: Percodan, Percocet, Darvon, Darvocet. There are topical preparations that contain methyl salicylate, so not acetyl salicylic acid, but methyl salicylate, and that is a more lipophilic and very potent form of salicylate. Oil of wintergreen is actually pure methyl salicylate, and a teaspoon of that contains 5 grams of salicylate. So it's actually enough to kill a small child, a teaspoon of oil of wintergreen. There's a lot of rubefacients, so things that are designed to be put on the skin to create a warm sensation and distract you from the pain in the muscle underneath that skin. And many of those contain methyl salicylate, so Bengay, Tiger Balm, Icy Hot, those kinds of things can sometimes contain menthol, but sometimes contain methyl salicylate. So the pharmacokinetics of salicylates are very complex, and we're going to talk about why that's important in terms of predicting toxicity based on a level. But when we think about the phases of pharmacokinetics in terms of absorption, distribution, and elimination of a toxin, every element of that is very complex when we think about salicylates. So when we think about a therapeutic concentration, that typically is going to occur within an hour or two when you take a therapeutic dose of aspirin. But that depends on the formulation. Remember that there's enteric-coated that are designed to not be absorbed immediately because they're really designed for their long-term effects on platelets and not for acute effects. The peak levels can be delayed in overdose for a number of reasons. One is prolonged dissolution of the pill, right? So when you think about taking a therapeutic dose of aspirin, you take 1 or 2 aspirin, you swallow it, it goes into your stomach, it dissolves, the pill starts to break down, it dissolves in your gastric juices, and then gets absorbed through the mucosa into the capillaries in your gastric wall, going down its concentration gradient into your blood. But when you take a handful of aspirin, instead of having pills surrounded by gastric juices, you have pills surrounded by pill. So there's less surface area available for the pills to start to break down and dissolve into your gastric juices. At a certain point, you exceed the solubility of the salicylate in your gastric juices. And remember that some of these preparations are actually designed to not start to break down until they get into the higher pH of the small intestine when we're talking about enteric-coated preparations. So these tend to form concretions and bezoars. Also, you get delayed gastric emptying. For all these reasons, the absorption can be really complex when you start to have large numbers of pills ingested. The distribution is also complex. So in a therapeutic dose, aspirin has a high amount that's protein bound, but that gets saturated in overdose. Also, the volume of distribution changes depending on the patient's pH. So salicylate is a weak acid with a pK of 3. At physiologic pH 7.4, it's mostly ionized. And that mostly keeps it in the vascular compartment and keeps it out of places where it would need to cross barriers like the blood-brain barrier in order to get into them. So as the patient gets sicker and the pH starts to drop, the salicylate shifts into its uncharged form and is able to cross barriers like the blood-brain barrier, and its volume of distribution actually goes up. Here we have on the top is acetylsalicylic acid, the bottom is methyl salicylate. And I have here a diagram of a 3-compartment model, the 3 most relevant compartments for salicylates, CSF, blood, and urine. And within each of those compartments, there's an equilibrium between the charged and the uncharged form of that salicylate. And it's only the uncharged form, the undissociated salicylate, that's able to cross between compartments. And that equilibrium within each compartment is governed by something probably a lot of you were hoping you'd never see again, the Henderson-Hasselbalch equation. When we think about the Henderson-Hasselbalch equation, if you're good at thinking in logs, then you'll know that if the pH is higher than the pK, then that difference is going to be a positive number, and that tells you there's more of the A- than the HA. If it's the pH is under the pK, it's going to be a negative number, and it's going to be more of the bottom. If you're not good at thinking in logs, another way to think of this is a more basic principle of chemistry called Le Chatelier's principle. And that says that if a stress or strain is placed on a system, the system shifts to relieve that stress or strain. So if you're more acidemic, that means there's more H pluses around. If there's more H pluses around, it shifts the equilibrium away from the side of the equation with the H plus. If you're more alkalemic, there's fewer H pluses, so it shifts the other way and dissociates. So that's a kind of intuitive way to think about it without having to think about logs. So the elimination of salicylates is also complex. In a therapeutic dose, it's mostly conjugated in the liver and eliminated that way. And urinary elimination isn't very important. But as the dose goes up, the hepatic elimination becomes saturated, and then the renal elimination becomes critical. At the cellular level, what's happening metabolically? How do you actually get poisoned? Well, it's uncoupling of oxidative phosphorylation. So remember, in order to get energy from metabolism, we generate NADH through glycolysis and the Krebs cycle, and the NADH passes its electrons down the electron transport chain, and each of those steps is coupled to a proton being pumped across the membrane, and then you use that proton gradient with ATP synthase to make ATP. When salicylate anion gets into the microenvironment on the side of the mitochondria with all the protons there, what does the salicylate anion do when it sees a lot of protons around? Right, this is what we were just talking about with the equilibrium. it picks up a proton, right? So if you have a lot of A- and H pluses, they come together and you get the undissociated form. And then when that happens, it can cross the membrane because it's uncharged. When it gets to the other side, there's not a lot of H pluses around because you've been pumping them across the membrane, and so it dissociates again. So what you've done is brought the H plus across the membrane without making ATP. So that's uncoupled oxidative phosphorylation. That's like what happens in brown fat, right? So all that energy that would have gone into making ATP gets wasted as heat. It's like a biological short circuit. So this is why patients with salicylate poisoning are hyperthermic. It's not a fever. It's that they're making heat in their mitochondria through oxidative phosphorylation uncoupling. So from an acid-base perspective, these patients are also complex, and it really depends on when you see them. Early on, patients typically have a respiratory alkalosis, and that's through stimulation of the respiratory centers in the medulla. This step you might not see in a young child because they don't have as much reserve to be able to generate that respiratory alkalosis. As the patient starts to get sicker, then you get a mixed picture. You get a respiratory alkalosis with a metabolic acidosis, and it tends to be an anion gap acidosis, right? Remember, this is part of your mud piles differential. And there are a lot of things that contribute to your acidosis. The salicylate itself is an unmeasured anion and can cause anion gap acidosis. You can get lactate from anaerobic metabolism. You can get ketones from inhibition in the Krebs cycle, proton shifts from the uncoupling. So a lot of things contribute to the acidosis, but basically what you see is an anion gap acidosis. But in this phase, you're still going to not have acidemia, right? Meaning your serum pH should still be over 7.4. As the patient gets really sick, they actually have an acidemic serum pH. And when that happens, that's somebody who is not compensating anymore. And that's somebody who is going to die soon. Because when the patient starts to have a pH under 7.3, then as the pH drops, remember that the salicylate tends to become undissociated. It picks up that proton, and then it becomes uncharged, and then it can cross into its site of toxicity, which is the brain. In terms of what you're going to see from a fluid and electrolyte perspective, these patients all tend to be volume depleted for a number of reasons. They have vomiting, both through local irritation of the stomach and because of through central mechanisms. And so they get fluid depleted, they get chloride depleted, and they get a metabolic alkalosis, so that you can actually have a triple acid-base disorder: respiratory alkalosis, anion gap metabolic acidosis, and a hypochloremic metabolic alkalosis from volume contraction and losing chloride in your emesis. They lose fluid through insensible losses in their sweat, and because they're tachypnic and hyperpnic, meaning increased tidal volume, they'll lose fluid in their breath. They lose sodium, potassium, and bicarbonate in their kidneys as well, and we'll talk more about that. Clinically, they're going to be vomiting, they'll be tachypnic, hyperpnic. Sometimes you can see pulmonary edema in severe cases. They tend to be tachycardic, diaphoretic, and hyperthermic, and sometimes you can see coagulopathies. And one way that I like to think about this is a sick salicylate patient at the bedside, or even from across the room, can look a lot like a DKA patient. That diaphoretic, kind of panting patient is somebody that you should think about in that differential diagnosis, in addition to DKA, thinking about salicylate. The CNS is the primary site of toxicity, and early manifestations of CNS toxicity includes tinnitus, right? So that ringing in the ear or buzzing in the ear that patients may describe. And you can see that kind of at the upper end of the therapeutic range. As the levels approach 30 mg per deciliter, you can start to see some tinnitus. Late is alterations of mental status, and that can be a wide variety of alterations. It may be confusion, agitation, severely poisoned patients may be comatose. And then the final common pathway is seizure, coma, death, because once the patient has a seizure, they get more metabolic acidosis from the seizure itself, and that shifts more of the salicylate into the uncharged form, which shifts more into the brain, and then that is kind of a fatal event in general. A manifestation of salicylate toxicity that you should be aware of is chronic toxicity. And this is actually much more challenging to diagnose. So instead of somebody taking a handful of aspirin, this is somebody who accumulates a super therapeutic concentration over time. And these patients tend to be much sicker than their serum concentration reflects because they have more in the tissues and less in the blood. These tend to be older patients, and they have a much higher morbidity and mortality. And this was from a study by Anderson and Gabot in 1976, and they were looking at outcomes in salicylate poisoning, and it separated into two groups. A group of mostly young patients, some of whom who were really sick, but mostly did pretty well. They tended to have acute poisoning and early recognition and treatment, and then a group of mostly older patients, and they tended to get diagnosed in a delayed fashion, maybe admitted for sepsis or admitted for rule out CVA to a neurology floor, and might not have been diagnosed for a day or two, and they tended to do much worse. And it's really easy to think about if you get a patient transferred from the nursing home who comes in, who has a little slightly elevated temperature, maybe a little confused, and maybe some lactic acidosis, and it's pretty easy. Okay, let's culture them up, give them some antibiotics. This is sepsis in a nursing home patient. We'll get them admitted. But if you don't stop and think about that salicylate poisoning possibility, it's an easy diagnosis to miss in this type of patient. In terms of evaluating them, if somebody tells you that they took more than 150 mg per kg of aspirin, that's a dose you should be worried about. Ferric chloride test isn't something that we really have available anymore. I think we were still doing it when I was a tox fellow, but these bedside types of tests are not really permitted anymore. But if you put a drop of ferric chloride in the urine, if there's any aspirin there at all, it'll turn purple. In terms of evaluating these patients, getting a urinalysis can give you some useful information. You can find out the specific gravity to get a sense of the patient's volume status. Following the pH of the urine is going to be really important when we start to treat them. Getting a blood gas with lactate is important in evaluating patients in general with acid-base disorders, specifically for salicylate, because it's going to give us important information in terms of making this diagnosis. It's often going to be the biggest clue. And then serum electrolytes will give us our anion gap. The glucose is going to be important. It can either be high or low. In general, the CSF glucose tends to be low, even if the serum glucose isn't. So patients who have confusion or alterations of mental status should get some supplemental dextrose, even if their serum glucose is normal. And then potassium is going to be important because you're not going to be able to alkalinize the patient, which is our initial therapeutic modality, until the patient has a normal potassium. Because when you're trying to alkalinize the urine, the kidneys respond to hypokalemia by avidly retaining potassium, and they do it by exchanging it for a proton in the urine. And putting protons into the urine is another way of saying making the urine more acidic, which is the opposite of what you're trying to do. So when we talk about acetaminophen, I'm going to talk about a really useful nomogram, the Rumack-Matthews nomogram. There's a nomogram for salicylates called the Doan nomogram that was developed to try to predict toxicity based on a known time of ingestion and a known serum concentration. And it just doesn't work. And it's because of all the complexity of the pharmacokinetics that we talked about earlier. Based on one known concentration at one point in time, you really can't tell how somebody's going to do. And in somebody with any significant salicylate poisoning, you're going to want to get a series of concentrations over time. And we're typically going to be repeating that level every 1 to 2 hours initially until we get 3 in a row that are going down. Because initially you may have a level that's rising, or you may see a level that's plateauing. If the patient has a significant gut burden of salicylate, they can have a balance of elimination and absorption at the same time. So until you really see a trend of a downtrending salicylate concentration, you can't really breathe easy. So how do we interpret that salicylate concentration? A therapeutic concentration is 15 to 30, but remember, people can start to have some signs of toxicity. As you get close to 30, you'll get maybe some tinnitus. With an acute ingestion, as I said, you start to get signs of symptoms over 30. If your level's over 100, that patient needs dialysis 100%. That's like the idiot level. But a lot of patients with levels under 100 will also need dialysis. So, if the level is 101 and you call renal, they'll say, okay, start alkalinization, I'm coming in, we're going to dialyze the patient. It's no real further discussion about that. But again, a lot of patients with levels in the 80s and 90s and sometimes even 70s might need dialysis if they meet other criteria for it. Chronic toxicity, remember that the serum concentration doesn't necessarily reflect the degree of illness. And as I said before, we're going to be repeating levels every hour or two early on. Even if the last level isn't back yet, send the next one so you have a steady stream of data. However many concentrations you have, if it's under 100, renal's probably going to want to know what the next one is. So you can just tell them, okay, right now the level's 80. I have another one in the lab. It'll be back by the time you get here. When we treat these patients, GI decontamination could be important. As I said, a lot of these patients are going to have a substantial gut burden of salicylate. In a large overdose, think about gastric emptying. Certainly going to think about multiple dose activated charcoal, so we can kind of keep whatever is in the stomach surrounded by charcoal. And multiple dose typically means 2 to 3 doses with a span of 2 to 4 hours in between. If you're doing multiple dose activated charcoal, just remember to use the charcoal without the sorbitol in it. All of these patients are going to be volume depleted. They all need fluids, so start with LR or saline to resuscitate them. And then you really want to avoid intubating these patients. This is really critical because when you intubate somebody, they develop a transient respiratory acidosis, and that can be a fatal event. And we'll talk more about that in a moment. Sometimes you do have to intubate them. You know, they may be really agitated and altered, and you're trying to get them dialyzed, and they're like trying to pull out their lines, and you just need to do it to get control of the situation. If you absolutely have to, and again, this should be an absolute last resort, really try not to intubate these patients, but it should be the most experienced person doing it. Pre-treat them with some sodium bicarbonate so that you can try to blunt whatever respiratory acidosis that they get transiently when you paralyze them and they get that period of apnea. You know, assuming that you successfully intubate them without killing them, you have to try to give them back what they were doing on their own in terms of their ventilation, and which is really hard to do. But you can't just do standard vent settings with like a rate of 12 and a tidal volume of 450 or something. You need to give them as high a tidal volume and respiratory rate as possible, as much as their pressures will permit it, in order to maximize their minute ventilation and try to give them back a respiratory alkalosis. So respiratory acidosis is bad because it shifts your equilibrium towards the uncharged form, and that shifts it into the brain where you don't want that salicylate. So what can happen then is, and then we've seen these cases at one of our institutions where a patient who was admitted to the ICU with significant salicylate poisoning got intubated by the ICU team with anesthesia, and the patient had seizure and then death. Peri-intubation mortality is a real thing, and you really want to avoid intubating, as I said. This isn't just theoretical. This is a model in cat brain with radio-labeled salicylate, and you can see that with a normal pH, so the black dots are where the salicylate is. It's mostly not in the actual substance of the brain. With the acidotic cat, you can see the salicylate throughout the brain, whereas alkalosis keeps it out of the brain even better than the normal pH does. So alkalinization does the opposite. It's good. It keeps the salicylate out of the brain and in the blood. And at the same time, you get ion trapping in the urine, and it helps you eliminate the salicylate. So how do we alkalinize? There's no one way to do it, but I think what most people do is start with a bolus of 1 to 2 milliequivalents per kilo of sodium bicarbonate. And then one recipe for an infusion is to start with a liter of D5W and put 3 ampules of sodium bicarbonate into that liter. An ampule is 44 milliequivalents of bicarb, so you're making something close to a normal osmotic concentration, but instead of normal saline, it's normal bicarb. And then we'll start typically at twice maintenance. These patients are going to wind up getting, if they're not hypokalemic already, they're going to start getting hypokalemic when you give them bicarbonate. So starting to supplement potassium early in patients who are able to make urine is a good idea. And your goal is to try to get the urine pH around 8 and try not to get the serum pH much above 7.55. And you need to maintain a normal potassium. So this is just showing the clearance of salicylate in the urine by urine pH. And you can see going from 5 to 6 or 6 to 7 doesn't really increase it that much. It's that jump from 7 to 8 that really improves your clearance of salicylate in the urine. One thing you don't want to use is acetazolamide to alkalinize the urine. I think at one point it was actually a recommendation in UpToDate, so you have to be careful with UpToDate because it's not really peer reviewed. But acetazolamide does alkalinize the urine, urine, but it does it by acidifying the serum, which is exactly what you don't want to do, right? Alkalinizing the serum is just as important as alkalinizing the urine. This is something that in animal models increases mortality and increases brain salicylate concentrations. So this is what happens when you give acetazolamide. You do alkalinize the urine, but you also acidify the serum. And so it's going to wind up shifting salicylate into that uncharged form, which can cross into the brain. So definitive treatment is extracorporeal removal or hemodialysis. Peritoneal dialysis is not really effective for eliminating toxins. It's fine for patients with chronic renal failure, but it's not really effective if you need to eliminate a toxin. So hemodialysis and hemoperfusion are modalities of choice. Hemoperfusion is kind of a vanishing therapy, but the idea is instead of putting the blood through a dialysis cartridge, it goes through a hemoperfusion cartridge, which basically runs the blood through activated charcoal, and the charcoal absorbs the salicylate, and then the blood gets returned to the body. Almost nobody has the capacity to do this anymore, and that's probably fine because hemoperfusion doesn't fix acid-base disorders. It only eliminates toxins, and modern dialysis cartridges are actually very efficient at removing toxins, and they approach the clearance of hemoperfusion anyway, so-called high-flux dialysis cartridges, which is what most people use these days. So the role of hemoperfusion is pretty much going away. Some patients may need CVVH, instead of intermittent hemodialysis, continuous hemodialysis. And depending on your setting, that might be available when intermittent hemodialysis is not, because it doesn't require a nephrologist. Critical care docs can do that. It's not as good as intermittent hemodialysis, but if that's what you have, that's better than not dialyzing the patient. And then in a small child, sometimes you can get a child with salicylate poisoning that's too small to dialyze. And in those patients, you can do exchange transfusions. So phlebotomize off poison blood and transfuse them with unpoisoned blood, and that's going to lower the concentration. So who gets dialysis? So people with clinical salicylism, right? So especially people with mental status changes. That's a reflection of salicylate in the brain. If they're getting worse, despite everything that you're doing, if they have renal failure and then you're not going to be able to enhance the clearance by giving them bicarbonate and fluids. If you can't alkalinize the urine for some reason, maybe they have congestive heart failure and they can't tolerate the volume load of getting your alkalinization. And then you have your level, right? If your level's over 100 and it's an acute poisoning, that patient needs dialysis. If the level is over 60 with chronic poisoning, that patient should really get dialysis too, although that will be more of a discussion with renal. All right, so let's look back at the case and kind of highlight some of the features that we talked about. So she had some nausea and vomiting, kind of classic symptom. Vital signs were normal, but were they really? Right? If the patient had an increased tidal volume because of hyperpnea, that doesn't really get reflected in your respiratory rate. And how often do we see respiratory rates of 18 or 20 that get written down in triage? That's actually tachypnic, right, for an adult. So maybe they weren't actually normal. She seemed a little strange. Was she having early CNS manifestations of salicylism at that point? So she had some tachycardia, and again, same issues that we talked about with the respiratory rate. So she had a pretty normal anion gap at that point, but she had a respiratory alkalosis. So kind of pure respiratory alkalosis is the early phase that you'll see. Had a very concerning salicylate concentration. This is somebody probably renal should be involved with. But got started on a bicarb infusion and initially didn't have that much of a decrease of the concentration because the patient was hypokalemic. And remember that as long as the patient's hypokalemic, you're not going to be able to effectively alkalinize the urine. And so once she got potassium, it started to be more effective. And again, classic signs and symptoms: nausea, vomiting, diaphoresis, tinnitus, just an absolutely classic case. So to summarize the salicylate part of this, just maintain a high index of suspicion. It should be an easy diagnosis to make in patients with classic salicylism, but that chronic poisoning is the one that is easier to miss. Evaluate clinically, urinalysis, electrolytes, blood gas, salicylate concentration. Treatment, and on a kind of a classic exam question: what is the initial management of this patient? Alkalinization. What is definitive management of the patient? Hemodialysis. In an infant, consider exchange transfusion, and treat the patient, not the level. So if, just because the level's under 100 doesn't mean they don't need dialysis. And obviously acidemia, I think I've hammered this point home. Acidemia is bad. It shifts salicylate into the brain. Any questions about that before I go on to acetaminophen? Okay, there's a lot of acetaminophen products out there as well. Tylenol is the one by far that we're most familiar with and is responsible for most of the poison that you're going to see. There's over-the-counter combination products containing acetaminophen. Just about every over-the-counter cough and cold preparation contains acetaminophen, and that's a common reason for overdose is that people are combining multiple preparations that all contain acetaminophen. Can be a reason that people take a super therapeutic dose. Combination analgesics that are either prescription or non-prescription, so Excedrin contains acetaminophen and aspirin and caffeine. Percocet, Vicodin, Darvocet, Furacet, all of these are pretty much every combination prescription analgesic, most of them contain acetaminophen. So the kinetics are a bit more simple in most overdoses with acetaminophen. In a therapeutic dose, you should get a peak concentration in an hour or so, right? If it took much longer than that, you probably would never take it for your headache. So we think about checking a 4-hour level, but just remember that in a therapeutic dose, you should start to see some absorption and a concentration that's going to be near its peak within an hour or so. Within most overdoses, it'll be within 2 to 4 hours. In really, really high doses in an experimental model that they were looking at using acetaminophen as a chemotherapeutic agent for liver cancer, patients with massive concentrations, sometimes the level would peak after 4 hours, even up to 8 hours after ingestion. That's usually not going to be that relevant because at that point they're well over our treatment line anyway, so we know that they're going to need antidote. There's a newer extended relief preparation that's maybe 15 years old at this point, and the kinetics of those are a little bit less well established. It's not a true sustained release preparation. It's like a 2-phase pill where half of it dissolves right away and half of it starts to dissolve after 2 hours. I think what happened is, I don't know if you've seen the old ads where they talk about, I think it was an ad for Aleve, that says if you take Tylenol for your headache, and it shows the large handful of pills that you have to take over 24 hours to control your headache, but these two Aleve will do the same thing. And McNeil, the manufacturer of Tylenol, got tired of that, and so they made this extended relief so you wouldn't have to take as many pills in a day. But unfortunately, it kind of threw a monkey wrench in the plans of toxicologists who are trying to decide who needs treatment. So what happens when you take a dose of acetaminophen? So almost none of it goes out in the urine unchanged, like less than 1%. So it's pretty much all hepatically eliminated. Over 90% either gets glucuronidated or sulfated. In kids, they tend to do more sulfation, and adults do more glucuronidation, but it adds up to about the same. And then a small amount, usually less than 5%, goes down your cytochrome P450 system, especially the 2E1 isozyme, and makes a very toxic and reactive metabolite called NAPK, N-acetylparabenzoquinonamine. NAPK is easier. And NAPK is really reactive. It likes to bind to sulfhydryl groups. But luckily, we have a sulfhydryl donor that's in the liver where the NAPK is formed, glutathione. And so glutathione detoxifies the NAPK that gets formed, and it gets eliminated, and it's not a problem. So you take a therapeutic dose of Tylenol, and every single time you make a little bit of NAPK, but it's not a big deal. We're able to handle it because we have glutathione. If you take an overdose of acetaminophen, the conjugation pathways of sulfation and glucuronidation are saturable. So you start to pour a greater and greater percentage of your dose down your P450 system, and ultimately you run out of glutathione. And so when you run out of glutathione, that NAPK starts looking for other sulfhydryl groups to bind to, and it finds them in cysteine residues in your proteins in the liver that's around where it's formed. It's so reactive, it doesn't get far before it finds something to bind to. So that's why it's toxic to the liver, is because it's formed in the liver, and the liver is what's around it, and that's what it binds to. The classic pattern is central lobular necrosis, and that's because that's where the P450 is. It's also the area with the lowest oxygen content and most susceptible to oxidant stress. Glucuronidation is also an oxygen-dependent pathway, so that also makes that area more susceptible. And this is what the pathology looks like. So top left is normal liver, bottom left is central lobular necrosis. You can also get effects outside the liver. The kidneys also have some P450, and so you can see ATN and acute renal failure, sometimes even without liver toxicity. You can get effects in the CNS, usually in patients who are already sick, but with massive overdoses, you can sometimes see CNS toxicity before the patient has evidence of liver toxicity. And this isn't somebody who takes a handful of pills. This is like the Costco overdose, where somebody buys that big bottle of like 500 milligram pills and takes a lot of them. Those patients can have early acidemia and early CNS manifestations even before showing signs of liver toxicity. We already talked about metabolic acidosis, and occasionally you can see pancreatitis. In terms of the liver, again, ATN is going to be classically what you see. So who gets sick? So just like aspirin, the dose that typically gets quoted as a level of concern is a dose of 150 mg per kg. That's not 100%. In a febrile child, we start to worry about lower doses than that. So, and kids are a very common group to get overdose on acetaminophen for a number of reasons. One is that maybe there are multiple caregivers who are not communicating well with each other. So somebody's giving a dose, somebody else is giving a dose. Also, there's multiple formulations of pediatric acetaminophen. There's the infant concentration, which is 80 milligrams in 0.8 mLs. And then there's the children's that's 160 milligrams in 5 mLs. And if you're using one of the dosing with the other concentration, then you can potentially run into trouble. The other way kids can run into trouble is they have a slightly older sibling who wants to give medicine to baby like they see the parents doing, and inappropriately has access to the acetaminophen. That's another way that the child can get poisoned. And they tend to get poisoned when they're already sick with some viral illness. And those patients are glutathione depleted to begin with. So we start to worry about those patients maybe with a dose of 75 mg per kg. In general, divided doses are better tolerated than a single acute overdose. So somebody taking a super therapeutic concentration over a period of time is probably going to handle the same dose a lot better. So like most adults can probably handle 10 grams of acetaminophen in a day and not run into trouble. But they're going to tolerate that 10 grams if you take it in 4 doses over the course of the day better than if you take it all at once. And that's kind of obvious when we think about the mechanism here about overwhelming your conjugation pathways. That's going to happen a lot more if you're taking it all at once than if you're splitting it up over a period of time. There's individual factors, right? So if you induce your P450, then potentially you're going to make more toxic metabolite. So common inducers of P450 include ethanol and anticonvulsants. Now, ethanol is a little bit of a tricky one because although chronic ethanol induces your P450, acute ethanol is going to compete for P450 and might even be protective, right? So the person who would at least theoretically be most at risk is the chronic drinker who didn't drink that day. So they have revved up P450, but no alcohol around to compete for the P450. This is always somewhat controversial because this is one of the most commonly taken medications in the world. And in the history of the world, there are, I think, 4 alcoholic patients that claimed they only took a therapeutic dose of acetaminophen and developed liver toxicity. They all had lawsuits against McNeil, the manufacturer of Tylenol. And were they uniquely susceptible, or maybe they took more than they thought they did, or maybe their liver toxicity might have been partly from the alcohol. It's not really clear, but if it does happen with a therapeutic dose, it's vanishingly rare because, as I said, there's millions of doses of this taken every year, and there's 4 cases that we know about that this has ever happened. So when I think about treating pain in an alcoholic patient, you probably don't want to give them NSAIDs, right? Because they're going to be at risk for GI bleed to begin with. You probably don't want to give them an opioid in somebody who's already abusing ethanol, and that interaction might cause worsening depressed mental status and respiratory status depression. So acetaminophen is probably one of the safest things you can give them. The only thing I would say is if I'm going to prescribe ethanol to a known alcoholic, I'll give 650 instead of the gram dose, 6 hours. And then glutathione depleted states, as I said, starvation, acute illness, especially in pediatric patients, is potentially going to be an issue. So again, when we think about that alcoholic patient, they're going to have revved up P450. They're not going to have enough glutathione. And so this is at least the theoretical concern in those patients. So we talked about with salicylates how useless the Doan nomogram is. This is an example of a really useful nomogram, the Rumack-Matthews nomogram, and this is well validated in a large population of real patients. And a few things to know about it. One, the line starts at 4 hours post-ingestion. Right, so there's no real way to apply this nomogram to concentrations that are less than 4 hours post-ingestion. So if you get a level of 100 at 2 hours or 200 at 2 hours, it doesn't tell you what the level is going to be at 4 hours. You don't know if it's going up, if it's going down. So the only level that'll be useful before 4 hours is a level of 0, because as we said, a therapeutic concentration of acetaminophen is pretty rapidly absorbed. So if it's 0, they probably just didn't take it. But anything else, you need to repeat that level at 4 hours if you got a level before 4 hours. So in terms of using this, you have to have a single acute ingestion at a known point in time. So if somebody doesn't know when they took it, try to get the best estimate, try to make a worst case scenario, the earliest it could have been that they took it. And then you have to have a level at a known point in time post-ingestion. If it's 4 hours, then 150 is the concentration above which we worry about toxicity. If it's sometime after 4 hours, just plot it on the nomogram at that time and see if it's above the line or below the line. You'll notice there's two lines. There's a line that starts at 200, and then there's a line that starts at 150. And the line that starts at 200 was the original line that Rumack and Matthews developed. And that was the line that was used in a lot of places for a long time. The UK, they traditionally used that. They recently changed. But in the US, we used the 150 line, which during the trials when they were looking at N-acetylcysteine as an antidote, I think there were 1 or 2 patients that were below the 200 line that wound up having some toxicity. And the FDA said, you know what, let's just drop that by 25% for a margin of safety. And the 150 line, just based on that decision by the FDA, became the line that we used. And after that, in the UK, where they kept using the 200 line, there would be periodic case reports in the literature of non-toxic paracetamol concentrations associated with hepatotoxicity. Paracetamol is the European name for acetaminophen. And they all tended to be between that 150 and 200 lines. So that kind of arbitrary decision by the FDA was probably the correct one. The other thing about this is that there's already a margin of safety built into it. So if you have a level of 140 at 4 hours with a reliable time of ingestion, then there already is a margin of safety built in. You don't have to worry about, oh, is that close enough? Maybe I should treat them anyway. If they're below that line, they're reliably not going to get sick. And as I said, this was validated in a large population of real patients. This isn't some theoretical lab-based nomogram. So again, single acute ingestion, known point in time, not really validated for extended relief preparations, but what most people have done is get a 4-hour concentration and then repeat the level 4 hours after that. And if either one is above the line, then we treat. Okay, already talked about that. Okay, so if somebody presents early, most patients are going to be asymptomatic for the first 24 hours post-ingestion. Sometimes they'll have some nausea and vomiting. That's pretty common just from filling up your stomach with a lot of pills of anything. Again, the massive Costco ingestion may have early depressed mental status and acidosis. We'll often screen people for acetaminophen poisoning who don't tell us that they took acetaminophen. And this comes from a number of studies that were actually looking at other things, but all 3 of them found the same thing, which is that in patients in the US who take a suicidal ingestion, who don't tell you that they took acetaminophen, 1 in 500 will have a level that's above the line on the nomogram. So this isn't 1 in 500 tox cases or 1 in 500 poisonings. It's 1 in 500 people who tries to kill themselves with an overdose will have a level that's above the line on the nomogram. So this is where our screening for acetaminophen in all psych patients comes from. They also usually want a salicylate concentration, which makes less sense because that's not a clinically occult poisoning like acetaminophen, where the patient initially is asymptomatic. But that's where all of that comes from. Somewhere around 18 to 72 hours, patients start to have elevations of their transaminases, and then they start to get worse and worse from then. 72 to 96 hours is when you get hepatic encephalopathy, extrahepatic involvement. And people who are going to recover are typically going to start to recover within 2 weeks, or they're going to die within that time frame. It's a pretty acute course. And people who survive after, even if they're in fulminant hepatic failure, if you did a liver biopsy a year later, it's completely normal. You can't tell that anything ever happened. So the liver has a tremendous ability to recover from this if they survive. So you really just have to try to bridge them through that. If the patient has a toxic concentration above the line on the nomogram, mortality is actually less than 5%. Liver injury defined as an AST over 1,000, that's numerical hepatotoxicity. 50 to 70% of people who are above the line on the nomogram will have that. Clinical hepatitis like jaundice and right upper quadrant pain is less common than that, and renal failure is somewhere around 10%. So treatment, N-acetylcysteine. N-acetylcysteine or NAC does a number of things that are specifically good for acetaminophen poisoning and some things that are just generically good for liver. And it's actually been proven to improve outcomes in fulminant hepatic failure of any etiology. But it enhances the sulfation pathway. It's a glutathione precursor. It's a glutathione substitute, so it can directly bind to NAPI and detoxify it. It impairs white cell migration to injury, so you'll get less inflammatory response and less injury to the liver from that. It improves hepatic oxygen extraction and cardiac output. And in terms of the efficacy, if you give NAC within 8 hours of ingestion, it's almost uniformly effective. Nobody's going to really have consequential toxicity if they get treated early. There's really no benefit to starting within 4 hours. Sometimes we'll get a patient who comes in that says that they took a lot of acetaminophen, and people get really amped to give the NAC right away because they know that giving it early within 8 hours is important. But giving it at hour 3 versus hour 6 doesn't make a big difference. So if they come early enough that you can get a concentration, find out what it is and whether they actually need treatment before doing it. But if you're getting close to that 8-hour mark, then don't wait for the level. Then you want to give it, because if you can always stop it if it turns out that the patient didn't need it, but you can never go back in time and start it within that 8-hour window. So you really want to get the NAC in when it's going to be most effective. And it's never too late for NAC. Sometimes we'll get a patient who comes in with fulminant hepatic failure. Maybe their acetaminophen concentration isn't even significant anymore. Maybe it's only 10 or something like that. It's still never too late for NAC. Even in those patients, there's a significant benefit on important clinical outcomes like mortality. So this is a study by Smilkstein. It's the same study that actually validated the nomogram, looking at percentage of patients who have a hepatotoxicity defined as an AST over 1,000 based on when NAC was started. And you'll see that if they got started within 4 hours or 4 to 8 hours, both of those groups did about the same. As you get after 8 hours, a higher and higher percentage start to have elevated transaminases. And if you look at the peak AST, you're going to see the same kind of pattern. So let's think about how we approach these patients based on when they present. So somebody who comes in really early, less than 4 hours post-ingestion, I'm usually going to give that patient activated charcoal, because I might turn someone who would have been right above the line on the nomogram into somebody who's right below the line and prevent them from having to be admitted and getting a whole course of NAC. Then at 4 hours post-ingestion, I'm going to draw a concentration and plot it on the nomogram. If it's above the line, they need treatment. If it's below the line, they can be discharged or they can be cleared for psychiatry if it was an intentional overdose. If they come in after 4 hours, then there's no point in charcoal, right? The level is what it's going to be, and they either need NAC or they don't. So we're going to send a concentration, and if it's above the line, they get treated. If it's below the line, they can be cleared. If they come more than 8 hours post-ingestion or close enough to 8 hours that you're not going to get a level back and get your NAC in time to treat them within 8 hours, then you're going to start the NAC before you get that level back because you want to give it as early as possible in that group. You're going to get the level, and if it turns out that it was below the line, then you stop it. You're not committed to giving it just because you started it. If somebody comes more than 24 hours post-ingestion, then we're going to draw LFTs and acetaminophen concentration, start NAC, and then either if there's any detectable acetaminophen at 24 hours post-ingestion, that's above the line and they need treatment, or maybe they don't have any more detectable acetaminophen, but their LFTs are abnormal. Those patients also should be treated at that point. If they're both normal, if they have no detectable acetaminophen and the LFTs are completely normal, then that patient's okay and they don't need any more NAC. For chronic ingestion, somebody taking a super therapeutic dose over a period of time, there's really not good data about how to approach those patients. You can't really use the nomogram for them. Some people look at the total dose in a 24-hour period and see if it was over 150 mg per kg in a day. The worst case scenario method is you assume they took it all when they started taking it and then put it on the nomogram. You're going to wind up with a lot of overtreatment that way. Some people try to calculate the half-life by getting 2 concentrations and seeing how it drops. None of those is really that well validated. The safest thing to do is just treat them. And I can tell you that in other countries, they have different approaches than we do. In Denmark, for instance, anybody who takes an overdose of acetaminophen, they don't even use the nomogram. They just, they're like, this is a safe antidote. It works. We're just not going to think about all this, and we're going to treat everybody. And so there are different approaches depending on where you live. So it's never wrong to just decide that, you know what, I'm not sure, let's just give them NAC. That's totally okay. But we can prevent a lot of admissions and unnecessary treatment if we identify the patients who don't need it. So in the US, we try to use the nomogram where we can. So there's 2 forms of N-acetylcysteine. There's the oral NAC, which is actually the same as the inhalation NAC. It's mucomist. This one is being used less and less, and I'll talk about why in a moment. So it's 140 mg per kg as an initial dose, then 70 mg per kg Q4 hours for a total of 3 days. It's really nasty. It has sulfhydryls in it. It smells like rotten eggs. So you want to dilute it down with like juice or soda, put it in something with a lid for somebody to drink out of so the fumes aren't going in their face, put some ice in it so it's less volatile. But still, people puke all the time. It's nasty. So aggressive use of antiemetics, Reglan, Zofran, and some patients may need a nasogastric tube. But again, this is a 3-day course of therapy. The newer antidote is the intravenous N-acetylcysteine. It's the same thing, but it's approved for use IV. It's sterile and pyrogen-free. And the dosing is different. So you give a 150 mg per kg IV over 60 minutes. And again, you don't have to memorize this. You're going to look it up when you need to do it. But then 50 mg per kg IV over 4 hours, and then 100 mg per kg IV for over 16 hours. If it's in fulminant hepatic failure, then you're going to continue that last part of it until they get better or they die or get a transplant. The advantage of this is that it's, first of all, you don't have to worry about the vomiting. Also, it's a 21-hour course instead of a 3-day course. So that saves them 2 days in the hospital. And even though this is a more expensive antidote, the saving 2 days in the hospital pays for the difference in cost of the antidote. And pretty soon it's going to be generic, and then there'll really be no reason to worry about giving the IV. I will say the one adverse effect you can get from IV N-acetylcysteine that you don't see with oral N-acetylcysteine is you can get anaphylactoid reactions. They tend to be rate related, which means they happen during that first phase of loading dose, and you can stop it and then restart after giving some Benadryl. And in general, most patients tolerate it, but sometimes people may switch to oral if they have a significant reaction to it. In general, these patients don't need to be in the ICU just to get their antidote, because if they're really sick, if they're in fulminant hepatic failure, then maybe they need to be in the ICU or better transferred to a liver transplant center. But if they're just getting treated because they have a numerical, if they're above the line on the nomogram, they're not sick, and they're probably not going to get sick for several days if they are going to get sick. So it's not something that happens very quickly. And so they don't really need to be in the ICU just because they have a level that's above the line. Late NAC, as I said, it's never too late for it. This is a study looking at acetaminophen-induced fulminant hepatic failure with a median time to therapy 53 hours post-ingestion, more than 2 days. They got randomized to NAC or placebo. And if you look at survival, more than twice the survival in the NAC group compared to the placebo group, and other secondary markers that are bad were less common with NAC than with placebo. One thing that'll be useful if you get patients who come in fulminant hepatic failure, the King's College criteria, not the King's County criteria, King's College in London, is one way to try to assess the prognosis. If there's acidosis after volume resuscitation, a pH less than 7.3, if they have hepatic encephalopathy, stage 3 or 4, a PT greater than 100, this was developed before there was INRs, or creatinine above 3.3, If they have more than one of these, they're likely to go on to die without a transplant, and they should be transferred to a transplant center. Newer markers, lactate, kind of like a lot of things, high lactate is bad. This is after volume resuscitation. They tended to have a lower lactate in patients who survived, higher lactate in patients who needed transplant or died. 2.5 was kind of the cutoff between them. And then phosphate is another marker you can look at. In general, as the liver is recovering, it consumes phosphate. Also, if you're in renal failure, your phosphate's going to rise. So low phosphate is a sign that you're doing well. And this is from a study by Schmidt. If you look at patients who had no toxicity or hepatic toxicity and survived, or even hepatic encephalopathy and survived, they all had phosphates under 1.5. In the patients who died or got transplants, only one of them had a phosphate lower than that. And maybe that patient would have survived without the transplant. So take-home points, acetaminophen overdose, really common. So common because it's in everybody's medicine cabinet. So anybody who's taking a suicidal ingestion, there's a good chance they took that too, even if they didn't tell you. If it's untreated, you can get hepatic encephalopathy and hepatotoxicity. When you get a single acute ingestion at a known point in time, use the nomogram to predict who needs an antidote and who doesn't. If it's above the line, they need N-acetylcysteine, or if they are a case where you can't really apply the nomogram, look at King's College criteria, lactate and phosphate, to assess the prognosis, and think about transfer to a transplant center early if they are likely to have a poor prognosis. And any questions? Yeah, I think a lot of people still have it at home though. So even though it's not sold anymore, you might find it in patients' homes. Yeah. Yeah. Yeah, Robbie? So you have to keep doing it because the psychiatrists aren't going to accept the patient without it. Whether it's really indicated, I think that's somewhat controversial. I showed you there's 3 studies that all kind of found the same number, that 1 in 500 number, but none of them were looking at that as the outcome. That was actually kind of, if you were looking at it critically, you could say those are hypothesis generating studies, and a study that's designed to look at it should be weighed as more valuable. So I don't know what the right answer is. I know the practical answer is that it's easy to do, it's inexpensive, and there's really not any downside. So, given that they're going to kind of demand it before they'll accept a patient, it's worth doing. Whether in the absolute empirical evidence sense, whether it's really necessary, I'm not really decided. But I think that if you call the poison center, they're still going to recommend it. Yes. Yeah, and specifically attempted suicide within ingestion, right? So somebody who has abrasions to the wrists or something, that doesn't mean that they need an acetaminophen concentration necessarily. There's no data supporting that. All right, thank you.